drops off gradually after that, peaks, but yes, it can go on further. It depends on how much tissue damage was done, right? A little bit, paper cut is different from huge laceration in terms of the phases of tissue healing and the time frames, right? It doesn't take 2 years of remodeling for a paper cut to heal. So magnitude of injury definitely affects all those cascades and time frames as well. But something like 2, 4, 6, maybe 10, 14 for more severe things. Inflammatory is a phase of tissue healing. That's where a lot of times pain is greatest, because that's where like prostaglandins and nociception is greatest. Does that make sense so far? Kick into the proliferative phase of tissue healing, which can last, let's say, weeks to months, but like peaks a lot of times, peak starts around 4 to 6 weeks, something like that, and then 6 to 8 weeks maybe peak, and then it kind of trails off after that. Then hopefully your body goes through like remodeling phases of tissue healing, and that can go anywhere from like something like 2 months to years. Your body has the potential to remodel. Does that all make sense? But why, like if that's true, if it takes like 2 to 4 to 6 days for inflammatory things to kick in, why did my femur fracture hurt today?
Aggravation.
What, say that again?
Like you aggravated and went back into the inflammation.
No, I wouldn't say that. If I snap your femur in 7 parts, is that gonna hurt tomorrow? Why is it hurting today?
Periosteum is innervated.
Yeah, like what I'm trying to say is like that's that magnitude of tissue injury, right? Like if you fracture your complex fracture of your femur, it's going to hurt now. It's not going to wait till tomorrow to hurt. But the fact that it starts hurting tomorrow gives you an idea, starts allowing you to stratify how significant is this tissue injury, right? It has to be small enough that you can feel something, but that you were able to kind of go through it for the first like 24 hours or so before the inflammatory phase of tissue healing got far enough. Thank you for being my visual aid. I want my pointer so that I can point for what
I got a dozen of them in there, but
does that all make sense? So that that's giving you information. It's giving you information of like what happened and how big a thing happened and things like that. So now let's talk about the body language. What are you all thinking when you see what she did? Which if I'm going to do my best. I'm not a dancer, but she's doing something like digging with, I forget whether you use her thumb. She's using her thumb and she's digging something like that, and then she's doing something like this with her hip. What's she doing? Like, describe for me if you were talking to someone who's blind but understands anatomic structures and movements. What am I doing? Am I stabilizing it? I'm not necessarily loosening. There's movement there for sure, right? And it's sort of like an internal extra. I'm in a little bit of flexion. I'm not extended, for example, right? Like because this would make me think of something different than this hurts. Does that make sense? Because like different structures are on tension or being pinched or something like that. So I'm in this position, little bit of hip flexion, digging my thumb into the anterior aspect of my femur, or I'm giving some away, femoral acetabular joint, right? Like anatomically, if you had X-ray vision, you're kind of looking through me. Is this where someone would point to their SI joint if it hurts? Because again, certain things allow you to localize pain pretty well. Visceral pain a lot of times isn't particularly well localized, but ligaments are usually highly innervated, and there's a lot of proprioceptors in there, right? So like if I hold my hand up behind my head and put 5 fingers up, you don't have to tell me 5 fingers are up. You don't have to tell me they're spread apart. I know that because of the proprioceptive input that's mostly coming from the ligaments. Muscles also have some proprioceptive input, and they'll feel how much stress I'm putting them on and how hard they're working. But a lot of that proprioceptive input of how far away are they and where are they located in space is proprioceptive input to the ligaments. Does that all make sense so far? Go ahead.
Are you saying that typically, maybe not always, but typically if the patient comes to you and they try to localize, point to it, and they stretch the area, that the injured area is more superficial, and that if they bend to relax it?
Not necessarily superficial or deep.
Okay.
But like I'm going to use a simple 2 muscle model, right? Biceps, triceps. Biceps, triceps are muscles fairly highly innervated from a proprioceptive input. And so you can localize them. You can point anteriorly to mean biceps. Like, am I pointing at my triceps from a certain standpoint, like gradually, right? Like the biceps is in the direction eventually of my finger, but because of the proprioceptive input to the muscles, I localize it by like grabbing my tricep and localizing and say it's here. So depending on how well innervated from a proprioceptive input standpoint, people will localize things differently. And again, if they're being point specific, a single thumb pointing anteriorly, it's something that is pretty significantly innervated from a proprioceptive standpoint. Does that make sense? And the position, one direction or the other, I'm thinking of, what's on tension or compression or whatever in this position, where you're pointing. Hip flexors are on tension in this position, right? So that Thomas test and things like that, psoas bursitis, for example, if it's actually bursitis and if it's not something else, like this kind of position would put tension on those things, as opposed to this sort of position, which would take tension off of those structures, but compress other structures. Skipping ahead a little bit, I'm more interested in like femoral acetabular pathology and impingement kind of motions when they're digging a thumb showing depth. Whereas like, if my rectus femoris was injured, I might do something more like this. And I'm not, you see how I'm not digging with my, I don't know, can everybody see okay? See how like, something here hurts. My rectus femoris attachment, I'm pointing to my AIIS, right? Something like that. Or I don't know, tensor fasciolata, like out here, and I'm kind of like squeezing or rubbing along the fiber pattern or something like that. And I might be doing something, it hurts me when I go like this, and I'm like putting tension on it so that me as a layperson, so that I feel it. Does that, like, patients you'll be poking on them, they might say, oh yeah, that's my pain, or sometimes like, yeah, I feel it when you do that. Probably you've heard that sort of thing that patients have said. But again, something like this, superficial kind of rubbing a little bit, is different from like the dig with your thumb and kind of impinge motion-wise. Does that all make sense? So I'm cutting ahead, given our time and wanting to finish a little bit. I'm interested in like her anterior labrum and the capsular ligaments on the anterior aspect. I'm interested in the hip joint, period. And now I'm gonna I'll probably ask her like 50 more questions, but we don't have time for any of that. Do you mind going ahead and lying down?
So really quick,
Mm-hmm.
so that for like 2 years, it started affecting more the issues that I have on my lower back,
Mhm.
and then came to these
So you had pre-existing issues in your low back.
I had 2 herniated disc and SI problems,
Okay.
and then 2 years later, the pain came on this one after I got assaulted.
After you got assaulted.
And COVID and all that, like, was kind of like a generalized.
So where's pain is still in the right hip, or where's pain on the left hip?
Right.
Do they hurt the same way? The
Mm,
same kind of pain, the same things that make it worse?
It kind of go back and forth, like
Okay.
some on my right, some on my left.
Okay.
I don't know it specifically right now.
Roughly same location, both anterior, both that you would point to something? Okay. Do you mind lying down for us on your back? And again, I'm not necessarily gonna have time to show you like absolutely everything I might do, but I'm gonna show you the things that are like coming to my head. So we've talked about like distinguishing hip joint pathology from SI joint pathology. I gotta tell you, like based on the HPI so far, I don't really think her pain is coming from her SI joint. That doesn't mean I won't screen it to sort of like make sure, like your physical exam should confirm your differential diagnosis in your head. If you're like, I'm worried she's got some femoral acetabular pathology, you need to check to see, yes, does that in fact correlate well? The more it correlates well, you need to do enough to sort of figure out what's her pain generator. And then if there's other things that overlap, you might want to check to make sure you're not missing something. Does that all make sense? So again, some of my exam is going to overlap a little bit with osteopathic structural exam. So some of how I test the SI joint might look a little bit different, but a lot of times I'll come up initially to the pelvis and kind of like push a little bit. Sometimes people call these like SI or sacrum compression tests. I'm maybe using my force a little bit different. None of that hurts or bothers you?
I got
Okay.
treated 3 times with
Okay.
PRP and exosomes.
Okay,
and stuff.
but none of,
I'm
no,
better.
still none of, oh, it used to hurt you to do this?
No.
Okay, so a lot of times I'll kind of, wiggle someone, kind of get them neutral on the table a little bit and just sort of see how things move. Again, that might be a little more osteopathic. I would usually start on the less painful hip, but because you're all on that side to allow so that my body's not in your way, I'm gonna go ahead and start on her anterior hip, okay? So a lot of times I'll just start with sort of basic flexion, extension, something like that, because if she's like screaming in pain like this, I'm not gonna torture my patient. I'm gonna do enough to sort of decide what's my next best step. And if she said, say she was a football player that was just out and took a hit and went down, and she's like screaming if I just do this passive range of motion, I'm not gonna be like, hold on, I gotta do a Faber test to figure this shit out while they're still screaming at me. I'm just gonna say, all right, I'm gonna send you to the ER to get an x-ray because I'm worried about a fracture. Does that make sense? Now that does not go along with her history, but I'll still kind of like see how well is she tolerating exams. Some of this is also like building rapport so that she knows that she can trust me with her leg, that I'm not gonna like, drop it. I'm not gonna like really shove super hard, and just kind of letting her get used to that I'm going to be moving her leg to allow her to relax. Because how many times have you been working with a patient, you're like, relax, rely, and like the more you like scream and shout, like you gotta get them to be comfortable with you having control of their limb. That's not something that's always intuitive. Usually the intuitive thing is people try to help. They want to be helped. They know you're a doctor, they're here to be helped. So they'll like lift their arm for you, they'll lift their leg for you, or something like that. You need to build that rapport so that they feel like they can relax. Does that make sense? So I'm kind of grabbing like this. I'm gonna come up, I'm feeling, again, this might be a little more osteopathic. I'm feeling how it moves as it comes up, and a lot of people will kind of tend to start like abducting out because of the orientation of the femoral acetabular joint isn't like a straight joint, the SI joint isn't a straight joint. So a lot of times people will tend to kind of come out naturally, but I'm feeling like those intrinsic forces as I kind of come up and see, are they guarding or anything like that? Is any of this painful so far? No? So from here, once I've established she's got the range of motion to allow me to do a good fader, I might, given where she pointed, I might start kind of coming in and seeing if I can elicit symptoms. So this one you might have to trust me on sitting there now. I wish I had time to like go through this one by one, and if we get a chance in the time that we have left, or maybe afterwards tonight, to be a little more specific. So for example, this is a fader test, flexion, abduction, internal rotation. You'll feel like a pinch in a certain part of your hip, right? So now I'm going to modify it and kind of change the orientation of her knee, and feel how I'm pinching in a different part of your femoral acetabular joint, or feel how I go further along and now pinch in a different part. So you can modify your technique to pinch on different parts of that femoral acetabular joint and kind of go along the front, the anterior aspect of it. Because if you have like a real specific labral tear, a real specific capsular thing, you could say, well, this looks like the picture, and feel how I'm not really pinching on anything right now. This is the picture. I've flexed, I've abducted, negative Faber test. Or you can kind of do something like this. Does that hurt or bother you? Yeah? Is that your same pain? So do you see how, like, again, have I fadered? Kinda, but like, I'm changing my sensitivity, specificity, I'm changing my positive, negative, predictive values by making little modifications to the test and feeling what I'm doing. Does that make sense? So if she points to a certain part, I want to, one, stress that part and see if I provoke symptoms. I also want to stress like nearby, see if I'm not missing anything, but also as a control, say she's not pointing out to a different part of her hip, I want to stress there and say, does that hurt? Because we've also probably all seen the pan-positive patients. Does this hurt? See. Does that hurt? See. Does that hurt? See. Does this hurt? See. Does your hair hurt? See. Your hair is not innervated. It can't hurt, right? So there are things that you might do, and again, in the business of pain management, we'll say something like pain out of proportion to exam, or non-anatomic pain, or things like that. But patients are suffering, and a lot of times what they're trying to do is communicate to you, I am suffering, and they want you to like take them seriously. So they'll start to say things hurt, even though they don't necessarily do. Does that all make sense so far? So anyways, I've found a spot here that hurts, and now, the next thing I might do is like, where specifically is that spot before I move on to other things? It's like, here that hurts?
Little higher.
Sorry, little higher? So, but that also hurts, correct? But little high, so like I'm like where femoral head meets up with the acetabulum, and the little higher is like up a little higher on the acetabulum. So not just at that joint line, but a little higher. And again, that's the level of specificity to tell you, okay, I'm doing my IA injection with or without ultrasound or whatever. Here's my IA, and I'm putting medicine inside her hip joint. Now I'm gonna like save a CC, redirect up, and hit like the edge of the acetabulum. Or I'm gonna pass the edge of the acetabulum to be a little bit higher up to maybe some other capsular ligaments or something like that that insert a little higher up. Does that make sense? And again, to not miss something, I might kind of come up to AIIS, and AIIS also hurts her. Does that make sense? And ASIS, that's not pleasant for you, particularly on the inside. And again, there's like push straight down on the ASIS, there's like push at it from the side, like tensor fasciae lata, that hurts too, but not as much as like iliacus does on the inside of ASIS. And AIIS, again, has, rectus femoris and things that kind of attach in that area. You kind of see how I'm like working through things, like not necessarily in maybe the order that you all might. Real quick to kind of distinguish, so I just did a Fay-Dur test, flexion, adduction, internal rotation to elicit symptoms. And I'm pretty confident those were femoral acetabular. But as an example, I'm gonna now put my hand underneath her SI joint and feel how, now I'm not impinging on your hip joint, but you feel how I'm like stressing some of those SI ligaments? Again, I'm same position picture-wise, my body language may be a little bit different, but now I'm kind of stressing her SI ligament while at the same time not pinching, like being mindful to not cause that impingement on the front. I can get maybe a false positive if I am not being careful, and feel how now I'm starting to have the hip part, so now I've got tension on the SI joint and I've got the impingement, and you would want to, in the same flexion, adduction, internal rotation, you want to aim your forces such that you're testing the thing that you think you're testing. That's going to come through your palpatory sense of where is the tension going to. Does that all make sense? Okay. So I have not done any, complete. I would want to know more before I planned out my injections, like trochanter, that doesn't bother you too bad. Like there's a bunch of things I haven't poked on. There's a bunch of tests I have not done a Fay-Dur yet, right? But I'm like starting to narrow down where I think her pain generators are coming from. I'm also starting to check other usual suspects to make sure I'm not missing something. And I'm putting that all together to say, well, what's the diagnosis, and therefore what's my treatment plan for one or more pain. She's got more than one pain generator, but she's got like one main pain generator. So maybe I don't need to focus as much on the ASIS or AIIS, and maybe if I was doing a one PRP injection, I might go for something more specifically femoral acetabular. But if I've got prolotherapy and I can put it like all over the place, maybe I would kind of try to treat more holistically from a tensegrity model to try to support that whole area. Sounds like there's some relationship with her back and things, but when I stress her SI joint, that doesn't seem to generate pain. So far, again, there's other tests to stress SI joint. Does that all kind of make sense? Like the flow, and I don't know, this maybe has taken 15 minutes or so. Most of it has been like telling you what I'm doing rather than it's faster for me to do it than for me to explain to people what I'm doing. So as you practice, as you develop these things, well, you can start going quicker to start sorting out and start coming out from a prolotherapy perspective. What are the pain generators and what am I going to be aiming for, and what's medically necessary to inject and what is unnecessary to inject? So for example, I'm going to poke right here. Painful at all on your pubic symphysis? People a lot of times, so pubic tubercle on the lateral aspect as opposed to pubic symphysis right in the middle. Like I might want to add that. And again, if you don't think of it, if it's not part of your process of these things are related or often missed, then you will neglect them. And to be a little more, again, holistic, the whole patient, you might want to start adding those things as you notice, hey, this person, my mentor, he gets good results. I want to be like David Wang, and I saw him do this, so therefore I'm going to start doing that myself to not miss things. That's how you will grow in this field.
I'm still waiting to grow.
Yeah,
Yeah, it'll happen. I'm still late bloomer.
I'm growing this way. Questions about any of these concepts so far?
So when you were doing like the immobilizing, like for the sacroiliac, so you flex